On behalf of Children and Family Futures and the Office for Juvenile Justice and Delinquency Prevention, thank you for joining us today for the Learning Academy webinar, Reaching the Tipping Point, Family Drug Courts as a National Child Welfare Reform Strategy. I would like to introduce you to Phil Breitenbuscher, Director of the Family Drug Court Training and Technical Assistance Program. Phil?
Thank you, Alexis, and thank you all for joining us today. We appreciate your time and interest in this topic. We are really excited about this topic and seeing how family drug courts can be part of the national conversation and looking at how it is surfacing to become a national child welfare reform strategy. I'm also very excited about the speakers who I'll introduce in just a moment. But first, let me talk to you about the Learning Academy. So today is, this is our second Learning Academy in 2013. This is our fifth learning community. And so far we've had 24 webinar presentations with over 1,700 attendees representing 45 different states. As I said earlier, this is our second webinar of the 2013 Learning Academy, which is called our Knowledge Sharing Community. Really what we're trying to highlight is sharing information across sites and across states in this learning community. Earlier in the year, in March, we had responding to domestic violence and family drug courts. If you weren't able to attend that webinar, it is posted to our website and would recommend that you go and take a look at that. It was highly attended. Next month, we'll be looking at our family drug court peer learning courts program and highlighting effective family drug court practices, so we encourage you to join that as well. As I said earlier, this is the second webinar in our fifth community. The other communities are listed up here on the screen now. We started with a planning community and then moved into early implementation, enhanced, and last year we did our advanced practice community. All of these webinars are posted to our website with additional materials, speaker bios. You can download those. You can replay the webinars. Also, background material, speaker information, other articles the speakers might have published are also included on our blog. So again, we encourage you to go to our blog, and we'd encourage comments and dialogue. So if you want to communicate with other peers across the country, please use our blog for that, and we'd love to keep the conversation going. So today's presenters, you'll hear from the Director of the National Center on Substance Abuse and Child Welfare, Dr. Nancy Young. She will speak first on the national perspective of family drug courts as a national child welfare reform strategy. And then we're going to hear from Gail Barber, who's the State Children's Justice Director in the state of Iowa. She's going to talk about how Iowa is really using family drug courts as a major reform strategy in their state. So before we get started, though, what I would like you to do is join me and join us in this first polling question. And the first question is, what agency or system do you represent? We would just like to know a little bit more about who is in the audience today. So I'll ask Alexis to launch this, and we'll give you just a few seconds here to respond to this first polling question. If you could respond now. So about 40% of you represent the court or legal system, and then a quarter of you are from the child welfare system, and just over 20% from the treatment system, and then we have some evaluators and others. So thank you all for joining, and we appreciate your time. We hope this webinar will be helpful for you. So without further ado, let me now introduce the Director of the National Center on Substance Abuse and Child Welfare and the Executive Director of Children and Family Futures, Dr. Nancy Young.
Thanks, Phil, and thanks Alexis and Russ and Kara and Jonathan, who make these webinars possible in the Family Drug Court Technical Assistance Program. I appreciate the opportunity to share some of the work that is going on at Children and Family Futures about family drug courts with everyone today, and greatly appreciate Gail Barber's participation that you'll hear from in a bit from Iowa and their expertise in looking at family drug courts and child welfare issues. So this is probably not a slide that's unknown to many of you on the phone. The reductions in the number of children and the entry rates of kids coming into care over the past decade has been remarkable. There are many different initiatives that have been put in place to make that happen. We've been monitoring all of that in terms of the efforts of the Children's Bureau in conducting the 2 rounds of Child and Family Service Reviews. we took a look at the reports on the CFSRs in connection with family drug courts and wanted to point out a few different kinds of things that we thought was somewhat interesting in the CFSR aggregate reports. In particular, under the allegation codes of neglect, substance abuse was the most frequently cited reason for the case opening. Now that's from the data that came from the case reviews that were done across the state. And I think for those of you that are on the webinar today, you're not terribly surprised by that. However, when we look at what kinds of reform strategies or what kinds of initiatives were mentioned in the program improvement plans and the efforts that are underway in states to address the issues that bring children into care or bring them into the child welfare prevention caseloads in home services, you see that family drug courts are mentioned, but not that often, particularly in relationship to many of the other sort of, if you will, mainstream kinds of efforts that are underway in child welfare in looking at the reforms that they have put in place over the last decade to ensure that those reductions, safe reductions in the number of children in out-of-home care and the number of children entering out-of-home care have been reduced over that decade. So we wanted to look a little further with that and to see how are family drug courts viewed in terms of these larger efforts of child welfare to look at their outcomes of safety, permanency, and well-being and the systemic factors. And we found that actually family drug courts are mentioned in the CFSR final report as having a positive effect in all of the states that we found mentions of family drug courts in each of the different outcome areas that they're mentioned in terms of promoting family child well-being, in the child safety and permanency, and also as a way to deal with some of the systemic factors in access to services. So they're an initiative that's recognized, at least through that CFSR process, as having a role in overall child welfare reform. We just launched now a second polling question, and we're asking, does your FDC have strong buy-in and support from the local, or if you're at the state level, the state child welfare service system? So go ahead and respond to that. To what extent do you agree with that statement that your FDC has strong support? All right, 80% responded to that question. Let's show those results. So nice, almost half agree that there's strong support from the child welfare system in supporting family drug courts as an initiative, and very few that disagreed that there was not, basically not support for the child welfare on family drug court initiative. So let's delve further into what do we know about family drug courts and where they're placed in this overall effort of child welfare reform and improving services and improving outcomes for children and families. If we look back for just a minute to the Adoption and Safe Families Act, those of you that have been around for some time, you recognize what was happening at this point, that the emphasis was on establishing permanency in ASPA, that there were no longer, or that there were initiatives in terms of making sure that children had permanency in their caregiving relationships, and that children staying in out-of-home care for extended periods was recognized as not something that child welfare wanted to continue to have happen for kids. During that era of the Adoption and Safe Families Act, there were actually 5 national reports that came out about substance abuse and child welfare, culminating in 1999 with the report from the Health and Human Services to Congress on blending perspectives and building common ground, the report that was required as a component of the Adoption and Safe Families Act. And when we look at those 5 national reports, we found very similar kinds of issues being raised as challenges in the field. challenges in collaborative practice, challenges in access to treatment, challenges in the way that the staff training happens across the system, challenges in terms of data systems, and really setting some frames about how collaborative practice needed to work. In terms of those challenges and identification of barriers, there were also similar strategies that were recommended in these 5 reports. And in fact, just prior to the issuance of these reports that came out, the first family drug courts were convened in what may be very familiar to you in Reno, Nevada and Pensacola, Florida in the mid-90s, that two enlightened family judges said, gee, with all that's going on in the adult criminal arena around adult drug courts, how do we take some of those practices and the principles and apply them in the civil proceedings of a child welfare case? And really understanding from that point that their extraordinary effort at bringing together the different systems that have very different mandates, different requirements of their timing, methods of how they practice, clearly some different training that they were all participating in, but individually by single system, and that the values and their requirements and their funding were often quite different, and understanding how that plays out in terms of working together at the case level, at the management level, and at the administrative level took extraordinary effort to understand what those mandates were and how those barriers could be resolved. They started with these new partnerships and some creative approaches, and a real recognition that if the Adoption and Safe Families Act said children could no longer remain in out-of-home care for extended periods of time, and that families and that children had to have a permanent plan for caregiving relationships for these children in a very short period of time, that the need for immediate and much more efficient interventions became paramount for families with challenges related to substance use disorders and mental health disorders. And that emphasis on creating more timely access in part helped to generate this very rapid movement of family drug courts over the past 15 or so years. When we look at those 10 courts that we could identify in 1999 to now most recent data, 346 courts across the country. This slide shows the concentration by the number per state. And we've also looked at that in terms of the population, the concentration by the numbers by the child population. And you see some different kinds of results when you look by child population. Obviously, with the number of kids in New York, Florida, and California, it looks a little different with some of the state leadership that's gone on across the country to really generate these kinds of approaches on behalf of families. We also understand from some evaluation work that was conducted by SAMHSA, the Substance Abuse and Mental Health Service Administration, in the early 2000s, asking Children and Family Futures to look at courts around the country to understand what is it that is unique about what family drug courts are bringing to this area of child welfare practice. And these bullets summarize the common ingredients that we found when we asked courts across the country, what is it that you're doing differently? The system of identifying families, great emphasis on that earlier access to assessment and treatment, that it was a quicker way in which families would get screened and assessment and some management of the treatment resources to ensure that there was some liaison role and brokerage role of staff to ensure that families had access to treatment services, increased management of their recovery plans, and look at much more frequently on compliance with treatment plans, recovery plans, and case plans. And that happened through increased judicial oversight, that instead of the sort of practice as usual, that once jurisdiction is taken in a case and when a child has been removed, and once there's a disposition, a case plan is put in place. Typically, what we see is that those families don't come back in front of the judge for about 6 months. And this was very different to say that the court was going to use resources to increase the judicial oversight to ensure that there was much more immediate reaction to compliance and inability to comply with court orders, or if not ordered, with the case plan and with treatment plans. So this was pretty revolutionary in the court system of saying we're not going to wait until the sort of standard court reviews, but to really understand what's happening about the recovery component of families to ensure that we're responding to the participants' behaviors much more quickly, using some good science behind that and understanding that that length of time was not going to work for families. So in looking at those common ingredients over the last decade, OJJDP in the last year and a half has supported the effort that just went out yesterday. We hope you got hit with several emails from different listservs for those of you on the phone that are actively participating in the Family Drug Court dialogue across the country. We hope that you got the announcement about the Family Drug Court guidelines. We hope that you will also visit the blog. We'll talk about that again at the end of our session today. To comment on the guidelines, to ask questions, to encourage your peers around the country to take a look at the guidelines. We've put that effort in to understand what courts are doing, moving beyond that decade ago of saying these are what drug courts do uniquely. Can we understand what participants in family drug courts are telling us now? This is what we found to work better. These are the principles about how we have developed our family drug court. We also were asked by the state drug court coordinators and embarked on review of the research to understand of those practices that were being generated from that more qualitative review of the court. What does the research literature back up in terms of, yes, this has been shown to be effective with family drug court clients, or if not with that particular population, is it based on research in the adult drug court arena in which we could assume or understand that some of those same characteristics in the adult drug court arena would apply for this population? So whenever possible, we identified what research has been done with both the scientific literature, the other publications that have come out, and have had many dialogues with experts about what these guidelines for standards that have been adopted by various states at this point should look like. So we're excited about the guidelines. We're excited about hearing from you about how the guidelines are being implemented, what you think about them. And again, we really hope that you will visit the blog and post some comments about what's going on with the guidelines. So with all of that work that's gone on, there's a real foundation that we can build on now. We know that the cross-systems collaboration in family drug courts, as well as in other arenas in which FDCs may not be operating, but there has been leadership to say new ways of working together across substance abuse, mental health, child welfare, and the courts need to be put in place. And we have lots of lessons about how to strengthen that partnership and how to create those linkages. We've seen evaluations that have documented the outcomes and the cost savings that have been achieved. There are tools that are available to assess progress, and understanding that evidence-based programs are increasingly being used in the family drug court arena. So with that reason for optimism, what have we found in terms of those outcomes? And you see them summarized here. These are some of the basics that have been generated across multiple local evaluations of family drug courts. You have more information on the specifics in the handouts from these courts that have had information published in the scientific literature, as well as some interim outcomes from the regional partnership grants from the family drug courts that have operated, the 24 sites that have operated in family drug courts in the partnership grants. So I'm not going to go into a lot of detail about those outcomes. Again, you have those in the outline in the PowerPoint that was distributed, and we would encourage you to contact us with any questions that you have about any of those specifics. But in general, you can see that all of those individual courts have shown higher reunification rates, fewer months in foster care and out-of-home care, infrequent new petitions, and those handout sides give you the details of those sites that we named that have been published in the literature. This is a comparison of children who remain in home. That's not a focal point in the evaluations that we mentioned in those sites that were on the map. But from the regional partnerships, we think important because this is not a way in which all the family drug courts that are operating across the country are looking at their eligible population. Many of them only intervene and have access for family drug court participation when the child has actually been removed. But in the regional partnership grants, a fair number of those sites worked both with in-home cases, kids weren't removed at the beginning of the participation in the partnership grant program. And so when we look at the performance measures of if the children were at home at the time of the initiation of the partnership grant program affiliated with a family drug court, what percentage remains at home throughout the life of the case. And you see 80% compared to the performance measures in the services as usual group that were reported from the various sites from the partnership grant. So we're definitely encouraged by that. That has a direct correlation to the number of kids not coming into care, which we think is very important. We also know that there are some unique distinctions that service providers, child welfare, and court staff need to be aware of when you're working with the in-home population versus the out-of-home population. And some of those lessons are emerging, and some are now well understood across sites with expertise working in with that population. We know that things are changing in family drug courts. From those basics that we talked about a decade ago about what's unique about the approach in family drug courts, we know that there's an increased interest in understanding not just the outcomes for parents' recovery, but what does that mean when you're addressing the entire family's well-being? Yes, it's holding parents accountable for their recovery and the systems accountable for the parent and child outcomes in terms of access to services and making sure that the systems are working together on behalf of families in new ways. But we also have much better understanding about the trauma experiences for children, but importantly also the trauma experiences of the parents and what it takes to ensure that parents are nurtured in a way that they can provide the healthy relationship that's needed with their child in order to successfully parent. We know that family stability and paying attention to the parent's needs as well as the child's recovery needs. And by recovery, I mean the recovery of their traumatic experiences that they have witnessed or experienced in their own right, and how each member has a treatment or a case plan that contributes to ensuring family stability and the processes that are needed for each individual to have an opportunity to recover from the experiences in their family, and then provide that family recovery, working together to reestablish parental roles and safe parenting practices and the kinds of things that we're witnessing when parents are able to reunify or to show that they're safely able to parent and to move forward, and to really look at that recovery and well-being as outcomes of the family drug courts, if you will, not just the safety and permanency, while critical, but moving beyond that to really look at the family recovery sort of outcomes. With all that, we can't say, gosh, you know, it's a problem in our caseload. I think it's a lot of our families who are affected by substance use disorders. We can't say anymore, gosh, we don't know what to do about it, because we have evidence of what's working in these sites. We have evidence to know what it takes to work together on behalf of these families. So how do we get from we know what to do in, frankly, some isolation of some individual courts? How do we move from those, if you will, boutique courts that sit on top of a system to understand if the majority of families in child welfare need this quicker access to services, and they need the monitoring that's going on in these kinds of initiatives? How do we create this effort that the family drug courts and other initiatives to address parental substance use disorders are part of the mainstream of child welfare reform? Is that too tall an order? Is that too much for us to do? Or is that our challenge in the next decade as we move forward? We're reminded of the work of the president of Children and Family Futures over probably now 20 years ago, when he laid out the concepts of collaborative practice and said there are stages that collaboratives go through. You go and move in these developmental stages, just like children, just like families, through stages of collaboration, of understanding each other's systems and information exchange. We hear that frequently in the very beginning of family drug courts. We just need to understand what they do. When you send a parent over to treatment, it's sort of this black box. What really goes on in that residential provider or an intensive outpatient program or less intensive outpatient? What is the information exchange that needs to happen? And then we see that courts or child welfare or the treatment agency will say, hey, let's do something together and do it different. And they create some sort of a joint project. Often that's with outside resources. Increasingly, we're seeing that it's being done with existing resources within communities, and we think that that's important to understand what can be done within the existing funding structures to understand that we could work better together. They often then uncover some of those rules that act as barriers. Many times they're the same things that were uncovered in those late 1990 reports that say, gee, we don't have a way that we're doing universal screening. Gee, we don't have shared case plans. Hey, we haven't understood what our outcomes are that we can monitor together. They need to look at those rules, understand those barriers, and create ways to change those rules on behalf of the whole family, and moving towards actually changing the system that's focused on the outcomes, the ones that we've already talked about: family recovery, child and family well-being, understanding those outcomes in new ways. So if we think about those stages of collaboration, where are we in the family drug court world in understanding how do we get to scale? Can we move from those pilot projects of the second stage of collaboration and really look at changing the system? Is this our push? Is this our challenge in the next decade? I think those of us that are sitting around the room in front of me in Irvine believe, yes, this is what is the responsibility of all of us in our country, to look at child welfare and to understand how do we ensure that the number of families who need these specialized services in order to parent their children have access to those kinds of services, so that we're able to look at the child welfare caseload and to expand those services in a way that responds to the needs of these children and families. One of the things that we do know is that just if you build a new way of doing practice, it doesn't necessarily mean that you'll get referrals or that parents will come. There's lots of reasons behind that. I think the expertise of the courts that are represented on the phone call today and others of your peers around the country have helped us identify what are those barriers that keep families from being able to access. I'll say it again because I'm hopeful that we have some representation of parents on the phone. Legal representatives of parents are often the linchpin in these kinds of an initiative. They have to make sure that they understand what this change in practice is and how the rights of their parents are being protected, and how this is a good thing for them to be able to participate. And that often is a key TA request that we have, is making sure that we're getting the buy-in of parents' attorneys, because it's key to making sure that we can get to scale. So I don't suppose that these numbers are accurate for the country. They're really put out here for all of you to look at your own numbers within your own jurisdiction, either at the state level or your local county or your local region. You need to have these numbers to understand your target. What is the target of scale? Meaning, what proportion of parents, of families who need these specialized resources are you actually serving? If we look at these numbers at the national level, so say there's, on average, 50 parents that participate in the average family drug court. And we know there's about 345 now family drug courts across the country. That means that about 17,250 parents are participating nationally in family drug courts. If you take the number of parents, and a figure that we've been using for quite some time is about 1.75 children per parent in the child welfare caseload, you may know better in your own jurisdiction. You may know that your proportion of parent to child looks a little different. I would encourage you to look at that, figure out what your proportion is, and find out how many kids in the child welfare caseload have parents that you need to address in terms of those number of parents who need services. Again, at the national level, there's about 408,000 now kids in out-of-home care. If you say the percentage is 70%, maybe you know better in your jurisdiction. Maybe it's only 40% of parents in your community that need access to specialized services for substance abuse and in the child welfare caseload. Maybe you're like some judges that I've heard that you say it's 95% of who actually gets removed that actually need services from substance abuse treatment. But the point is not, is the 70% the right number nationally? The point is you need to know locally what percentage is justifiable to your legislature or to your local board of supervisors. What do they agree is the concentration of parents with substance use disorders in your child welfare population? Is it 40%, 60%, 70%? What is the number of kids in both in-home and out-of-home care that you need to have specialized services for? In this example, we're looking just at those kids in out-of-home care. So we come up with a round figure of about 285,000 children whose parents are affected by substance use disorders who need these specialized services. Okay, so if you back up to, we think it's about 30,000 kids of parents that are currently receiving services in a family drug court per year, so 50 parents per year, 30,000 kids. If you take that by the population of kids in out-of-home care, the 285,000, you have about 10% that are actually being served. So if 10% of the children in out-of-home care we think are currently being served, what's happening for those other 90% of kids and families? What happens to them? We also know that judicial leadership in convening interagency players and being a partner in tracking the outcomes over time has led to some of these family drug courts going way beyond the number of 50 per year on average. How did those family drug courts get so big? What happened in terms of the system changes that needed to occur in their jurisdiction so that more parents got access to these services that they needed in regard to their substance use and mental health disorders? We know that the buy-in of the treatment agency and the child welfare agencies is key. We know that they began to recognize that parents that were participating in family drug courts were doing better, and that was important in order to get their buy-in. We know that they had leadership on their data systems, that they tracked their outcomes and looked at a way that they could sustain the monitoring of their outcomes over time, and that they conducted evaluations that included enough cost offset data that they could take that to their state legislators or take that to their local board of supervisors to say, this is what's happening in our family drug court and the kinds of resources that we've used and what we need to move forward. What do we know about why some family drug courts stay small? They often will ask us for technical assistance about this, and we find out that they're not getting referrals. And sometimes it's because they have very discrete inclusion criteria, and that their exclusionary criteria is broad. Only certain kinds of parents are given access to these kinds of services. They may have not had a full complement of the partnerships that they needed in their community in order to ensure that they had the services available. They may have not had the resource that they needed to monitor recovery outcomes. Some of the solutions that we've seen for that is some of the restationing or outstationing of substance abuse counselors in a way that may have not increased the actual resource, but may have reconfigured the job description and reconfigured where those staff were positioned that could offer that recovery case management that was needed. They figured out communication protocols that were able to respond to much more efficiency in the way in which the systems communicated. And they looked at dockets of how that was happening so that there was specialized knowledge that was being accumulated by the practitioners and with the court so that they could respond to these families. I've mentioned some of these solutions already, how the parents and attorney get buy-in and understand what the advantages are for parents, and that the exclusionary criteria often means that some of the toughest families to work with might have been screened out. And in fact, we know that some of the evidence supports that this increased monitoring and this increased resource works best with some of those toughest cases. So we know that small is fine if you know that the population that you're serving is really this high need population that needs this high dosage of services, that the payoff becomes much bigger because these were families on a trajectory of very high cost, that you were able to put the brakes on those costs. We know that in some jurisdictions, perhaps the total need is smaller, or perhaps it's a very small rural county that you don't have the need for a larger number of families to participate. Our point in this is you need to know that percentage. You need to know your penetration rate. That example that we gave of knowing the penetration rate is key to say, we're small, and this is why. Or we need to be able to get a bigger number of families referred to us. You may have a specialized docket that's looking just at 0 to 3-year-olds, and they're prioritized in your state or in your community to say that's where we really need to put the emphasis. Or the substance-exposed newborns, the SEN acronym, substance-exposed newborn hospital costs, are what are generating the need to provide these specialized services for families. So knowing the population, knowing the penetration rate, knowing your target in terms of what family drug courts should be doing in your community is key to say, yeah, we're small and that's the reason why. So that discussion was really just about scale, the scale of your penetration of the family drug court. What about the scope? We hear often that the numbers are one thing, but the number of services that families need in the full range of needs for children and families means that the expansion of the partnership is needed to really look at the scope of the services that are being delivered. There are some current trends that I'm sure you're seeing, that we're seeing in terms of changes in how we monitor technical assistance requests, for understanding the trauma experiences of families, for understanding the increase in opiate use, both prescription drugs and the illegal use of opiates that is reoccurring, reemerging across the country. We know a lot about the co-occurring conditions of families and the kinds of services that are needed in terms of those concrete supports, housing and economic support and basic transportation, co-occurring kinds of conditions in terms of the mental health services that are needed, domestic violence services that are needed, those kinds of needs driving the partnerships and driving the scope of the family drug court to ensure that those kinds of multiple supports are made available for families. We also know that in the push to understand what works best, that there is some experience about those kinds of services and what's in the evidence base. And what does it mean to really be family-centered in our approach? And what does it mean to pay attention to the prevention and the intervention needs of these children of substance abusers who are at very high risk of developing their own substance use disorder? So when we think about the family drug court as an island within that larger construct of child welfare services, how do we ensure that they don't become isolated and sit on top of a system that's unable to really track its impact on the larger system? How do we ensure that there's not infrastructure that is not developed to understand what's happening in these tough fiscal times, so that we're laying that groundwork of the infrastructure to move forward in the lessons of the 346 now drug courts across the country to look at the scope and the scale. Now take a minute and talk about some of those funding issues. These are the federal funding sources that we've identified that have gone into funding family drug courts. When you add those all up together, we'll come back to that, but it's some $22 million a year that is put into often pilots, demonstrations, grant-funded projects. If you look at a community and say that this line is sort of the landscape of the community, and these pilot projects sit on top of this community. They're not integrated into the mainstream of the way in which services are being delivered. They sort of sit on top of the landscape. And sometimes we go to a community and they say, yes, we're working with our substance abusing families. We have a family drug court. And we ask the question, how many families are participating in your family drug court? And we hear something like 15 in a community in which there are thousands of children in out-of-home care. That's what we're talking about when we're saying these are pilots that are sitting on top of a community, that are using outside resources, that have not yet looked. What are the real resources in the community that are sustaining the kinds of practice that's going on in these systems? How do you get a handle on what the changes are right now in Medicaid in states as they implement the Affordable Care Act? What resources in TANF are being put into treatment and economic support for this population of families? The other services that we've been talking about, domestic violence and mental health and physical health and the courts, the police, and the families themselves. What kinds of resources are there in order to ensure that we're looking broadly in our communities about what could possibly be redirected to ensure that the scale that's needed for families with substance use disorders has possibility of really getting to those penetration rates? Or are we allowing money to be piled on in isolation in our community from an unchanged system? Are we looking at those stages of collaboration and saying we're moving towards systems change because we understand that our parents are doing better, our children are doing better when they're having their substance abuse issues addressed early on in their case plan? I mentioned that $22 million in a year that's going directly from the federal government. We recognize there's a lot of private resources. There's a lot of resources that are happening at the local level, at the state level. But when we look nationally at that $22 million, it sits pretty much in isolation from the ways in which services are being funded in Title IV-E, in TANF, in the Social Services Block Grant, in Medicaid, in the Substance Abuse Prevention and Treatment Block Grant, in the 4B services that are supporting families, and importantly in Medicaid. That's our challenge. If we say we must go to scale in order to give all of these families the hope that's needed, then we have to get real about where the money is and what's happening in our community, in our states. We have to be strategic about that. You probably don't want to sit at your first collaborative meeting at the state or local level and say, show me the money. We have to first say, what's going on in our community? Can we document that the outcomes for these families look better? Can we say that this project moves the needle on safe reductions of kids in care? Can we say it moves the needle in increasing the number of families in which children don't go through the process of removal? Does it move the needle on our child welfare outcomes? And if so, what would it cost to go to scale? What would it cost to increase the scale of these programs by 10% or 20% or 30%? How do we get strategic about knowing what the results are from our family drug courts, knowing if it's effective, what components could be and should be expanded? And you're going to hear me say it one more time. What is the scale of the family drug court that we're operating? What is the penetration rate? How do we monitor that in our collaborative meetings? Are we looking at that penetration rate on a quarterly basis, on a monthly basis? Is it something that shows up on the wall that says this is the percentage, this is our goal, this is where we want to go? Is it something that's monitored on a regular basis? We know that in those communities that they have gotten bigger, that they are able to show that it works, they show that it saves money, they show that they're working collaboratively in new and better ways. They're able to tell their story. the data nuggets that have emerged from their jurisdictions, coupled with the stories of the families that have been the beneficiaries of the marketing approach. They're able to describe this in the, if you will, elevator language, that it's not a three-sentence paragraph when you get the opportunity to say, what are you doing over there in that family drug court? What's the language that's needed to be able to tell the story? How they're engaging their policy leaders early on to understand what message is going to be credible to those stakeholders that are making these decisions about these jurisdictions and their budgets. What are the kinds of ways that they can hear the message and construct evaluation data that responds to what it is they're looking for? Do they care about the prevalence of the issue? Do they mostly care about the developmental outcomes of the children? Do they care about family recovery and the intergenerational impact? Are they looking at the outcomes for children in isolation, perhaps, of the larger family? What is it that these stakeholders want to know? Or is it strictly the bottom line cost savings? Because what that negotiation with your stakeholders early on helps you do is to be able to craft your evaluation in a way that it tells the story of the family drug court. With all of that, and my time coming to a close, I'd like to say there's a magic wand, that there's a way to just say, gee, you know, add this, this, and this, and things for families are going to improve. Instead, we know that there are initiatives that have led to evidence in each of these areas about what needs to come together and the range of tools that are available to jurisdictions to be able to use. But we also know that those of you on the webinar today and your colleagues around the country with this expertise, they're the leaders. You're the leaders. We're not the leaders at Children and Family Futures or the National Center on Substance Abuse and Child Welfare or the Office of Juvenile Justice and Delinquency Prevention. You are the leaders that are going to propel this movement of child welfare reform that is able to carry the message, and you are tomorrow's champions that will move forward in better serving and improving the outcomes for families that we're all sitting around these tables seeking to help in different ways. I thank you very much for your time today. I look forward to questions, and make sure that you are visiting our website, sending us emails with your questions, and particularly, please do visit the blog, post questions, post comments, even if you think, gee, nobody's posted anything on this topic yet. Be brave, be a leader. I want to know something about this, or I need to have some help from my peers around the country about a topic. Take that leadership role and help us out with being active in communicating across the country. Thank you very much. And Phil, let me turn things over to you.
Thank you very much, Nancy. I appreciate that. And just to kind of piggyback on the idea of the blog, we know lots of people are hitting on the blog. Last night alone, we had 600 hits on the blog, and so we do want that communication. If you have questions and you want peer feedback, put it on there, post a comment, and then if you see that comment, feel free to join that conversation. So let's go ahead and do another polling question. What is the greatest barrier, in your opinion, facing sustainability and institutionalization of family drug courts in your community? Is it the need for champions? Is it the need for a cost analysis? Is it the lack of sufficient data on your program outcomes? Or is it a resource problem due to the state and local fiscal crisis? So a majority of you, or 56%, think that it's a resource problem due to state and local fiscal crisis. And hopefully some of the things that Nancy spoke about with regards to understanding those larger resources underneath and to access some of those larger funding sources will be helpful for you. Another 20% said the data, and I think those two things go hand in hand as well with the need for champions. The champions can carry the message of the data, and that hopefully makes the case for redirection of funding. So We appreciate your feedback on that, and now I'd like to turn it over as we think about how is Family Drug Court a child welfare reform strategy, and you heard from Nancy talking about it from a national perspective and how states and local jurisdictions have been able to move forward and really going to scale. We're going to now hear from Gail Barber, who's the director of the Iowa Children's Justice Center and the State Court Administration, and how they have done and begun this work on working differently in the state of Iowa. So, Gail?
Gail, would you try and call back into the line and re-enter your access code? And in the meantime, Alexis, have there been any questions that have come in?
Yes, in regard to the 4 stages of collaboration slide that you showed, there was a question about what roles need to be changed. What rules need to be changed? Maybe we can speak a little bit to some examples of rules that would be changed to increase collaboration.
So one of the things that we hear frequently in terms of those kinds of barriers is rules about who gets trained. So if the training is happening in isolation by system, that it may be a rule that can change to say, gee, when we do the training on the way in which parents get access to substance abuse treatment, it shouldn't just be within the treatment system.
Okay.
We need to bring others on and understand those training rules and requirements that we can change. Are there ways that we can look at the CEUs for professionals at the state level that gain better access? There are some others that we can come back to, but I heard Gail, and I hope we can move forward now.
I'm sorry about that. Anyhow, thank you, Phil, and thank you, Nancy, for including us. In 2006, not uncommon in other states, Iowa had a substance abuse problem. 70% of our open child welfare cases were due in some part to parental substance abuse. Iowa was 3rd in meth labs, 3rd in the nation in meth use. We were about 8th, and TPRs were increasing because families with parental substance abuse couldn't meet the ASSO guidelines. We actually didn't realize every other state was struggling with the same issues. What we knew was we weren't serving our families well. The Office of Drug Control Policy sounded the alarm. Meth Land was published about one of our local communities, and drug endangered children chapters were starting, and some of them had a very law and order approach. So we were all talking in our silos. Judges were talking to judges. Social workers were talking to social workers. And we all wondered, what do we do? How can we do better for our families? We had a champion emerge, actually. The judge wanted to attend. We had a judge asked to attend a national conference on drug courts. She came to the Court Improvement Project, which is, our name is Children's Justice, but it's Court Improvement Funding. And she asked for assistance. All court improvement projects are required to have some sort of steering committee, and most of them are multidisciplinary. Ours is very representative of the child welfare system, so all our members were like, you bet, go for it, we'll fund your way, go find out how to help. So this judge became our first champion, and she came back. She started a teen drug court and then a family treatment court. No funding, no grant. All we did was support her to go to this conference, which actually she heard Nancy Young at. But she was a determined champion who said, we need to do something different, and I'll figure out how to do it. She went to her local substance abuse provider, DHS, and we had an opportunity then to apply for an in-depth technical assistance through the National Center on Substance Abuse and Child Welfare. We gathered, we picked up the phone, we gathered our partners, DHS, the Department of Public Health, the Office of Drug Control Policy, and we said, we think we should apply for this. Since CIP, or Children's Justice, was built on the concept that collaboration is critical, we were kind of in the best position. We were used to building collaborative teams. So we picked up the phone, we called them together, we said, could we apply? They agreed to be our partners, and we wrote an application for IDTA. At the same time, the regional partnership grants were coming out, and we wrote for that grant as well. At the time, not realizing that, number one, how much work it was involved in both of those, and number two, that you really didn't need money to move forward, except for this one champion judge who had done a great job, and one other judge who picked up on that and became a champion in his own right. If it wasn't, it definitely wasn't that we were heroes, that court improvement was a hero at all. It was just that we were the first ones to pick up the phone. So cross-system, a lesson we learned right away is cross-system is critical if you want to successfully serve these families. On the next slide, in-depth technical assistance, they really helped us get a concept of what really needed to happen for us in Iowa. First, one of the toughest things I think was developing an MOU to work collaboratively together. So were we going to share data? Were we going to be responsible on the IDTA committee? What else were we going to do? And everyone was stressed, just like most of you. Everybody's busy. Your caseloads are high. The workload from the federal government and from the state government is high. But we decided we could work together collaboratively, and IDTA helped us put it into writing. And as you can see on the slide, the information about our technical assistance work is on the website at the bottom of that slide. And I think it also might be on the blog as well. So we developed, ambitious as we were, busy as we were, we developed a 70-page drug protocol. And I don't know about you all, but we have lots of good textbooks and other kinds of documents. We used a lot of the information that IDTA and that Child and Family Futures had put together, but we developed a drug protocol that was a tremendous labor of commitment, but it was definitely too big to be a desk guide. So we, in the end, developed a 2-page guide that has been much more helpful for our judges and our social workers. We developed through IDTA, we had a committee that worked on a multidisciplinary release form. So we had definitely the substance abuse providers at the table. We had the Department of Public Health and DHS at the table to make sure that it met everybody's legal opportunity to be able to share information. And we also developed a protocol that would allow the state agency and the substance abuse agency to share information together about common clients they had. And eventually, legislation was actually enacted that supported and required this protocol to be used. A pitch I would put about the IDTA and the National Center is the National Center on Substance Abuse and Child Welfare had sponsored some sessions at National Center for State Legislators meetings. And one of our legislators just happened to go to one of their meetings. We didn't know it, but all of a sudden legislation started to be crafted, and then contact was made with us and our partners, and so we had an opportunity to mold the legislation so that it better met the needs of the people actually doing the work. An agreement was also made by all our partners, all of us, that we would take the online learning as a national center. If you haven't looked at it, there's online learning for child welfare professionals about substance abuse and substance abuse treatment. There's learning about child welfare for substance abuse providers. And there's one also on for the legal field. And that was really important for all of us to begin to develop a common language. So we had the same learning, and we understood kind of the parameters of each of the fields that we worked in. With all of this good support, I have to say we were slow learners, and we were slow to partner with each other. We were all busy folks, and some other folks even saw that the court was really kind of mucking in their business, but we persisted. We were sure that if we continued to work together, that we'd be able to do better for our kids and our families. The other thing that we did was, on the next slide, talked about regional partnership grants. we read everything we could. Nancy mentioned the Blending Perspectives publication. We pulled that out, and this was in 2007. But we looked at the 1999 Blending Perspectives, and we recognized a program from Illinois that I had been involved in before, which was called Project SAFE. We read the SAFER book. If you haven't seen the SAFER manual, you should take a look at it. And I can tell you today, on page 57 of the SAFER book, it talks about family treatment and case planning. This was a very, very tough piece that to get teams to look at and to be able to implement. So, but we wrote the RPG grant. We were ultimately successful to get that. Totally surprised. I'm very, very happy about it. And in that grant, we developed 6 pilot sites. Because we're a statewide project, we really looked at having some rural sites, some medium-sized sites, and a couple of metropolitan, the 2 largest communities in our state. We asked that they each locally develop a steering committee to address the more local context of their communities, but keeping a statewide concept that there are some key elements that have to be in every court. Those key elements are listed. Some of them are listed on the slide, such as early substance abuse, assessment and entry into treatment, regular, frequent judge-led. I won't read the rest, but the things that turned out to be most helpful for us were really the recovery support services. So we wrote in that we would have a recovery support specialist for up to a year beyond the official case closing. Our families had told us that they felt most vulnerable, although happy, when everybody got out of their lives officially, but that's when they felt most vulnerable. And so we built in that extra support, primarily based on the Blending Perspectives and Building Common Ground and Project SAFE, to say we can do that. We'll find a way to keep an experienced person who has been through the system or some dedicated recovery support person that knows the resources in the community to help stay connected with that family. Coordination of delivery of services was really occurred through our building our treatment teams, which were available at every treatment court session. We did multidisciplinary training, and we also wrote in an annual update to legislature. So during this grant opportunity, what we actually were able to do, besides providing good service to families, was to begin to build in place the necessary people, both at the state and the local level, that could end up changing policy and practice at the local level to improve the outcomes for children and families. When we received our evaluation, we were pretty astounded. It was a feel-good program. Everybody that participated felt good about it. Judges talked about it being a life-changing kind of experience for them. Families talked about it sometimes as a life-saving experience for them. So, and we had great anecdotes, but the question really was, did it really help? Our evaluation says absolutely. So you see some of our data there. One of the things that we think of this data that was maybe most important for us is 98% of the parents entered substance abuse treatment versus 68% entry rate for a matched comparison group that didn't participate in treatment court. That was really pretty important, considering that we know the longer somebody remains in treatment, the more likely they are to be able to continue to recover. Again, on the next slide, we see that the length of stay in treatment for the parent was 4 times longer. So really quite a substantial difference between the two. For some folks, the cost avoidance was really the most important thing to take a look at. And I think it's incredibly important. We were astounded that, in fact, we could do feel-good work, that it was effective work, and that, in fact, it could be cost-effective. But I think equally important, we just kept talking about it. We talked to our own organizations. We talked to committees. We talked to anybody that we could think of to continue to inform them about what we were seeing and what we were learning. For some of you who have not contacted your court improvement project, they're required to be collaborative. They're also really good about, they are the most active leaders in juvenile court that I have ever met, and they are always looking for ways to serve kids and families better. So I would say find out who your court improvement project director is. It's also helpful, certainly, to know who your court, your drug court coordinator might be, but Iowa doesn't even have one of those. But court improvement has, there are several states that are really interested in taking a look at family court, treatment court through court improvement. So it's just another suggestion that I would have. On the next slide, we talk about family treatment courts. Something else was happening. Additional family treatment courts in Iowa started surfacing. We had judges call and say, could we be part of your project? We didn't have any additional money, but we provided technical assistance to them about how to replicate the existing family treatment courts. That was kind of our first clue that the talk that we were providing, that all the treatment court sites were providing, would be helpful. Funding helps. I don't want to deny that, because we've certainly benefited from having grants. But what we found is it wasn't essential. If you have a champion, you can find a champion. If you can find a technical assistance, and right now we provide some of that. We also rely on the National Center and the National Resource Center for Court Improvement. We rely on them as well. But you need to have that, build a community team who can learn more about substance abuse together, and that, as I said, is available online, and that they will begin to support the local community to develop a treatment court as well. The other thing that we did, and it was a promise we made to the Supreme Court, was if we wrote for this grant, because in Iowa at least, the court seldom writes for grants. It was, if you're going to do this, then you must come up with some standards so that we don't have treatment courts emerging in a variety of different models and maybe no kinds of accountability. So you develop the treatment court standards that you think are essential for any community to have. We did that, and they are right now on the Supreme Court's table for adoption. They're under consideration, and we should know a little bit later this summer whether they will be adopted as is. The treatment court standards were designed to establish some uniformity across the states. The decisions that we made a difference for us. We took a chance. We sent a judge to training. We had that champion who we asked to present at judicial conferences. That sparked another champion. That judge built a new team in a new community, and he encouraged us to support other judges to develop their own teams. On the next slide, we talk about the decisions that made a difference. We kept the state-level steering committee together from the time IDTA was awarded to us until the present day. We have the same state-level steering committee together. The Department of Human Services Child Welfare Director, the Department of Public Health Behavioral Health Director, who is also responsible for substance abuse treatment services, and the Office of Drug Control Policy. We look to them for guidance. We provide lessons that we're learning from our treatment sites and from our expansion sites. We discuss the circumstances they face, such as funding and fiscal problems and staffing problems. But we also ask them to consider ways that they can address the barriers that we're seeing that could help solve the problems for families and children. We also ask each of our sites to have a local steering committee to address the local issues. There are sometimes cultural contexts. There are issues of lack of funding or lack of understanding of substance abuse. We provide education to them. We encourage them to educate their community leaders about substance abuse and the impact it has on their community. And every step that we make is really collaborative. We ask that you learn who your champion is. Who could your champion be? It might be the judge. They're good at convening, and people attend when they convene meetings. But it might be the graduate that can tell their story. It might be the intolerant landlord that finally understands what happens to kids when their parents get evicted and figures out a way to join in your local steering committee and work differently. It might be the social worker who has worked so hard and has been frustrated because nobody else understands the work that she's doing or he's doing. So look for someone who can help you the most. Who are your champions? And maybe it's you because you're on this phone call. But keep looking for partners. Again, check your court improvement project. See if you can meet with someone there to learn what their focus is. What are the things that they're trying to address? Inform them about what you know about the data. Money sometimes brings people to the table. In our case, it brought the substance abuse providers in our local site to the table. But it doesn't take money to learn to work together differently. Again, on the next slide, we talk about keeping the issue and the solutions on the radar for everyone. Some of the things we did was we provided all-site meetings for all our treatment courts. We'd pull them together once a year and have them talk about what they were doing, but also bring in national experts or bring in state experts on how to work with families, how to work with children and families, how to provide substance abuse treatment in women's and children's services. CIP funded some cross-site visits, so we would support a judge who was interested to go visit another site that already had a court up and running. We provided judicial forms. You can see the list that's on there. But we also provided, Nancy actually mentioned keeping your attorneys as key. One of the things that we did in each of our pilot sites was ask the judge to convene a meeting with all the attorneys that serve on child welfare cases. The first question we had was, why would I want to put my parent through this? So they get scrutiny more often and they have to do drug tests more often. How is that a good decision for my client? But we had the local judges convene local meetings for attorneys, and the judge and also other providers were able to talk about why family treatment court, including some parents that had participated in family treatment court in another site, for instance, would come and talk about why family treatment court was really the best thing for them to happen. We maintain a steering committee at the state level. We also maintain a steering committee. We ask them each to have their local steering committee. Staying at the table. I guess one of the things that made us know that some changes were happening was that when our RPG grant was over, we informed all of our providers. Well, from the beginning, we talked about it being, we start with the end in mind. So this is not a refundable, this is not a replaceable grant. We will not get another grant to fund this. So when 5 years is up, there will be no more money at the table. So we all need to be working on sustainability. Most of our sites didn't do a really good job of looking at sustainability, hoping that maybe we would pull a rabbit out of the hat or someone else would find some funding. But we talked to them about it, and all of our providers, except in one site, have decided to stay at the table. And the other site, they stay at the table. They just don't come quite as frequently. But they all found working together was better for kids and families. They built relationships. They trusted the knowledge and commitment of each other, and they called on each other for consultation. Each site now is looking creatively at how do they meet the needs of families by reaching out to community services, faith groups, housing, employment. But the most important item that really kept them here is that they are all working together differently, and that mattered for them. The court, in addition, is working on adding a different kind of court position. So taking what might look like a court attendant position and making that position much more a court coordinator position to help with the family treatment courts and other adult treatment court and teen treatment court too, because they saw how much more productive it was to have the family treatment courts in operation. So what signs did we see that there was a change? Well, professionals were learning about parental substance abuse and child welfare. Many of those professionals served in other areas where there were no treatment courts, and they were like, we can do this. We can operate differently. Other signs we began to see, actually we weren't looking for systemic change. We just wanted to serve kids and families better. But we began to see those signs in neighboring counties. A judge here, a worker there, they began to talk about what they learned in family treatment court. We realized that then it was like, we better think about this more carefully. We realized that the most rural courts will never be able to have what we consider a family treatment court. When you have hearings, 10 cases, and you have hearings a half a day a month, it's hard to say you're going to then have weekly or biweekly treatment court. But what we're asking them to do now is to look at the essential elements, and we're helping them with that. What are the essential elements, and what can we adapt to a rural community that doesn't have the substance abuse resources in their community, and they have to go 2 counties away? I'm sure you all have rural areas too, but in terms of thinking about Nancy's, taking it to scale, we decided to find ways to support all parts of our state with the lessons that we learned. In closing, I just want to talk about a couple of steps that we have decided to do. We'll continue to have the state-level advisory committee. We met with regional managers, actually, and talked to them about what we were learning, and they were like, that's great for your treatment court workers, our treatment court workers, but what about all the other workers throughout the state? So we decided to work with the National Center on building their online learning into a live professional training, profession-specific, so that there will be a training built into the state agency social work curriculum. There will be one that the substance abuse professionals will have built into their ongoing curriculum, and there will be one for attorneys and judges that will be built into their curriculum. And we're real confident about the legal professional one because we basically are in charge of the attorney and judge training for juvenile court. So we know for sure that one will happen. We also have a commitment. The Substance Abuse Professional Training Group is incredibly excited about working with us on developing a child welfare training for substance abuse providers, including they are contributing some of the match dollars for our present grant. Finally, we are offering multidisciplinary training, and we are developing a summit on permanency that we will be offering in the fall. It will include national experts, but also feature some of the programs that have been put in place, our family recovery specialists, how to do joint case planning, some of those kind of breakouts. So anybody within the state that's interested can learn more about what they can take back to their local community. I hope that this has been helpful. If you have any questions, we're certainly willing to be contacted, and all our material is on the National Center's Family Drug Court blog and on the National Center website. Phil, Nancy, thanks for allowing me to be part of this.
Thank you, Gail, and I appreciate your comments and your words there. And you know, as we were talking earlier, as Nancy was talking about changing the rules and responding to that question, I want to give her a chance to add a few more responses to that. But also, you know, I'm listening to Gail, and I'm thinking about the slide Nancy showed where there was all of that, those other large funding sources down below, underneath kind of the surface. And sometimes that slide gets put up, and I see people's faces still like overwhelmed by that, or that seems like such a daunting task to tap into those larger funding sources. And I think you heard some things from Gail, and that where you can see how those funding sources are being tapped. When you're talking about court coordinators being assigned, that's tapping into the court system to assign coordinators. That's not outside necessarily new funding, but it's redirecting existing funds. When we look at states, and we've heard that in now a couple states across the country where they're now assigning family drug court coordinators to jurisdictions through court funds. When we're hearing about effective services for children like child-parent psychotherapy, and that becomes, and they work with the state Medicaid program to get that Medicaid eligible, that you've changed the rules, you've changed the system, and you've accessed new funding sources to sustain your programs. And these are small things that add up to large things. And I know, Nancy, you have some other things you want to talk about changing the rules.
Well, I think one of the areas that we hear frequently beyond the training as one of the ways in which jurisdictions have to look at what's going on at present, what's current practice. Over the last decade or so, as we've been part of implementing the National Center on Substance Abuse and Child Welfare, when we go out to a state or a community and do some assessment of what are your strengths and what are your challenges and what are your priorities of what to work on, there are four things that almost always come back as the first areas of need. The first is about working agreements to figure out how are they going to share information, how are they going to work together. Gail talked about that in Iowa as developing the MOU. There's almost always a need for some basics of how we're going to share information in particular that has to get worked out in a written agreement. The second is about how the jurisdictions are doing screening and assessment. And they often start with what's the screening tool that we need to implement at either the emergency response component, but typically more at the investigation phase of the child welfare case. What's the screening tool that we need to use? And then in follow-up, if there's a positive in that screening tool, what's the assessment that we need to do in order to fully understand what kinds of substance abuse services are needed by this particular family? So the screening and assessment component is often really key. What we ask jurisdictions to do right along with that is also to understand what are the needs of the children. Are there developmental assessments that are needed under the Part C or under CAPTA? Is there a requirement that this child be sent for a developmental assessment? How do we understand both the prenatal exposure effects on the neurodevelopment of the child as well as any postnatal effects from trauma histories or other separation from parents that they need to have assessments done. So it's screening and assessment both of parents and the substance abuse issue. And generally, jurisdictions get that really quickly, and they typically will say, what are the 5 questions I can add to my investigation tool that are going to help me understand what kind of treatment the parent needs? And working through, it is the team that comes together to understand with the family what their needs are that create that change. So the screening and assessment for parents with a substance use disorder, as well as the effects of living as a child of a substance abuser and what kinds of service needs are needed by that particular child. Or if the child is a little older, what kind of intervention and prevention needs that child needs in their own right to prevent them from developing their own substance use disorder. Then the fourth area that we hear almost always is how do we look at some of these, if you will, big ticket items in funding. What are the rules about how we're spending our 4B dollars? Are there assessment components of this need to understand better the challenges for families that are fundable under the 4B grants that go to states? Are there CAPTA grants, the funds that are available? Are children's trust funds available? What kinds of things can be funded in terms of repositioning staff under 4E? All of those rules and requirements that sometimes are at the federal level, but typically are rules that are set at the state level about how they're creating their state plan for both the 4E, 4B, and TANF dollars that come into the state, as well as the Substance Abuse Prevention and Treatment Block Grant. It's those kinds of inventories that need to be done to understand how are funds being used at present. Some of the systemic change that we've seen is in jurisdictions that will look at those funding streams and say, the Substance Abuse Prevention and Treatment Block Grant has some requirements on it in terms of the amount of funds that need to go to prevention. is not this a very high-risk population in terms of prevention funds for kids? And how much of those prevention dollars in the block grant are being allocated to preventing substance use disorders among the child welfare child population? Also in the substance abuse prevention and treatment block grant, there's requirements for ensuring the maintenance of effort on pregnant and parenting women and persons who are using IV drug use. Right behind that, we've seen jurisdictions prioritize access to treatment as the next population that has to get access to services, families who are known to the child welfare system. And in those jurisdictions that say, we prioritize for access to substance abuse services, the child welfare population, the gender mix of who goes into treatment changes pretty dramatically, because often the persons who are gaining access to the SAFT block grant dollars are persons who are involved in the criminal justice system. And it's a tough discussion to have on, are those our priorities in our community? And they very well may be. But they also may be criminal justice involved families that are also child welfare involved families. And knowing those numbers and knowing who's getting access to those block grant funded services now allows you to look at, if not written rules, implicit rules about how practice happens right now, and what does our community believe about prioritization of services for families. So those 4 areas of developing common agreements, screening and assessment of families' needs, the training that goes on across systems, and the funding. Those 4 areas almost always emerge as the priorities that jurisdictions want to work on when they're working with us in a technical assistance plan. I hope that's helpful, and there's additional information on some of those barriers and solutions that communities have put in place in an monograph that CFF, Children and Family Futures, put together about 1.5 years ago, that we looked at the framework that we use of system elements and tried to capture in a very short synopsis of jurisdictions around the country that have addressed those barriers and what their programs look like. The collaborative practice model is available on our website, or email us and we can make sure that you get the link to get some ideas about what other jurisdictions have done to address these barriers in their communities. Phil?
Yeah, thanks, Nancy. And there was just another question here that we'll address real quickly. And the question was, are there any opportunities to set up trust accounts for core programs? And we've received this question quite often, and sometimes we've seen, and I actually serve on the California Collaborative Justice Courts Foundation, and our mission is to help provide funding that the state and federal funds cannot pay for to support drug court clients. And there are many, if you go onto the National Association of Drug Court Professionals website, there's a link to state foundations. So I would say starting with what's already existing, whether there's already a state foundation in your jurisdiction. If there's not specifically a drug court foundation, there may be a child abuse prevention foundation. There may be your treatment providers have a foundation. It's a lot of work to set up your own foundation and to maintain that foundation. So looking first at what's there and who can you partner with, I think would be a better first step. And then if there isn't anything or someone you trust in setting up an account for you within an existing foundation, you might look at setting up your own 401c3 and going through that process. But it does take some work, and I'd be happy to talk with you more about that if you're interested. Just send us an email, or we'll have some of those links up also on our blog. So I'm going to wrap up here. Again, we encourage the conversation to continue. If you have additional questions, you can either go ahead and type those into the dashboard on the right of your screen, and we'll take those questions once we conclude the webinar, and we post those questions to the blog, as well as send those back to you by email. But as you think about, is family drug court a national child welfare reform strategy? I think we really have to think of 3 things. We have to think about, are we addressing the need in the way that Nancy spoke about in terms of scale and in terms of scope. And are we clear about our target population? Do we have the outcomes that really move the needle for those who are interested in funding and supporting these programs? And how are we suited with the other parallel initiatives, both nationally and in your local community? And have you done that inventory to see that you are working in partnership with those other initiatives rather than in competition with them? And just to give you one last tool, because we do think this point about scale and target population and parallel initiatives is so important. Here's one really easy way, and maybe easy is oversimplistic, but here's one way that you can understand your population a little better is looking first, knowing the number of children with substantiated allegations in your community, and knowing the number of children that enter foster care annually. And then what percentage of those, or what number of those, are children of substance abusers or affected by substance abuse? And then is there a more discrete population that you're planning to work with, such as parents with severe substance abuse issues, or children who are born substance exposed infants? Are you able to clearly articulate that target population? And again, if you haven't revisited that target population in a while, I guarantee your child welfare population has changed over the last few years. And other initiatives have emerged in your communities. And there may be an initiative that is serving that exact same population, and that's why you're no longer getting the referrals you used to get. So making sure that you're working not in isolation, not fragmented from the larger system, but with the larger system to be sure that you're meeting the need of the community. And that may mean changing who your target population is. And then you can justify what your scale is, and you can say the impact that you're making on those larger outcomes. So again, being clear with that, I think, is very helpful for you in saying how you are a child welfare reform strategy. Again, Nancy talked about this earlier in the presentation, and we are very excited about it. You can go to our website. It's actually on our front page, but here's the direct link. And at the bottom of your screen there are just released and approved by the Office of Juvenile Justice and Delinquency Prevention, the guidance to states, recommendations for developing family drug courts, and we're going to do a webinar here in a couple months where we'll really unpack what those recommendations look like and how you can best use this resource. But essentially, it's based on a foundation of shared mission and values, and you heard a lot about that today from both Gail and from Nancy. And then we have these kind of two parallel pillars of improving your collaboration services, or the way you work with your teams, and improving services for your children and families, all towards the end goal of shared outcomes and improved outcomes for children and families. And that's kind of the way it's set up. Really, this document sets up recommendations, strategies, and research findings on best practices and collaborative principles for family drug courts. But what it also does in its appendix is set up and provides you with a facilitator's guide and structure to set up your collaborative structure, and it really walks you through what Gail talked about and how do you set up the state teams. We have in the facilitator's guide sample agendas and sample announcements. We've provided you with who should be at the table, what the description is of each level of that governance structure, from the administrative oversight, steering committee, and your team staffings. And so not only does it provide you with the practice principles, it provides you with a facilitator's guide on how to implement this in a state and local areas. Gail talked about the online tutorials, and here's the link for those if you're interested. I won't read each of those. You can see those on your screen, and we encourage you, if you haven't done so, take a look at those. And if you're interested in taking one of those, we do offer CEUs for you. You can visit our National Center website. There's the link again for other presentations coming up, trainings, tutorials, toolkits, publications, and videos. And also a last plug here for our Family Drug Court Peer Learning Court program. These were 5 courts selected to serve as our peer learning courts, and they are willing to share their information with you, their policies and practices, their screening forms, their eligibility forms. They're willing to set up phone calls with you if you'd like to talk with them about how they're operating in their jurisdictions. And next month, you'll hear from Pima County and what they're doing with Jane Pfeiffer, who is the Senior Associate of the Peer Learning Court Program. So please register for that webinar, Family Drug Court Peer Learning Courts, Highlighting Effective Practice. That registration is now open. So we'll move next month to starting this at 11 a.m. Pacific time or 2 p.m. Eastern. So the registration is now open. You can go there to register. Also, please visit our blog. We've said it many times, and there's the website, familydrugcourts.blogspot.com. Please visit that blog, and let's keep the conversation going. And with that, I will conclude it. Thanks again to our speakers, Dr. Nancy Young and Ms. Gail Barber. Thank you very much for your input and guidance on this. And thank you all for joining our webinar. Please complete the evaluation. We do appreciate your feedback. And most importantly, thank you for what you're doing on behalf of children and families. Have a great day.